calling you out. No, I just have two quick announcements. Okay, first one, because I kept forgetting to say it. Relay for Life is next Saturday from 12 p.m. to 12 a.m. They would really like a good portion of our class to at least volunteer for 1 hour. You just have to stay for 1 hour in between that time slot. There's a sheet taped up here for you to sign your name for whatever one is best for you. And then also, Shalanda said they have a couple schools that were asking to have students come and talk to their class about the PA profession just as like a professional day. Like I think it's even elementary or middle schools, like it's not high school, and I think there's like 1 or 2 schools. So we just need like 1 or 2 people if you want to partner up, but just let me know if you're interested, and then I'll give those names to Shalando and he'll get with you about that. So that's it.
All right. I have my CPT book here. I know it says 2010, but I bring it because it's got so much of my notes involved, and I want to pass it around, okay? And you can see a lot of the procedures that are here, labs, cath, all of that. So pass it around, look at it, don't look at it, whatever, and you can sort of see how a CPT book is done. All right, we've got a lot to cover in this next hour, okay? The OIG, government agencies are watching you. Okay, we're going to talk about the they're watching. They are. The OIG, and we're going to, these are all of them, oh, and there's more than that, but we're going to talk mostly about the OIG and the CERT, okay? But real quick about the racks, okay? Well, I think I do talk about the racks. No, I don't. Okay, the rack audits are this. Basically, the insurance companies, they come in and they say, we want 45 of your records. And then they determine whether those records match up to the billing that you billed out. And if they don't, you owe back money. Okay, now you have 45 days to comply, and you know it can be very laborious as far as getting that information to them so that they can see it, and then it comes back to you, and then you've got to say whether you're going to fight this ruling or not. And if you don't fight it, then they keep track of that too, because they say, okay, obviously you don't fight it, so obviously you must be guilty. And so they keep track of that, and then they tell the other agencies that. And so you have to owe back the money, and then they'll keep watching you. But if you fight it and say, well, no, we do agree with that, and then you have to take time to fight that and to send the documentation to prove that. So basically you're looking at charts over and over again. You've got staff looking at charts, you've got staff running off charts and sending them. It's a lot of work. Hospitals have someone dedicated just to the rack. They have a person dedicated just to keeping track. And you have 45 days of which to comply, and then after they give you the ruling, then you have so many days in order to disagree with the ruling and fight back on it, or else you owe them the money back. And there's all these time frames involved. And guess what? The people that do the rack audits, they are outside contractors that the government has contracted, and guess what? They get a piece of the pie. So if they find that your practice has overbilled by $500,000, guess what? They get a piece of that $500,000. So of course it's in their best interest to find issues. So everybody's getting a piece of the pie. And meanwhile, the physician's getting squeezed more and more and more. Right? Okay. The OIG, it is the largest office of the federal government employing 1,700 to combat waste, fraud, and abuse in Medicare. Okay? OIG came into a hospital that I was not working as a coder at this point. It was before I started being a coder. They came walking in the hospital, knocked on the door with papers, and all the coders had to back away from their desks. They confiscated all the computers, and that hospital came under a corporate integrity agreement, had to pay money back. In 5 years, they were under more government scrutiny, and it was a huge deal in our state. Okay, and you'll hear them over and over again. In fact, I hear a lot of Florida doctors get hit and all stuff like this. You know, they're billing for Medicare people that are dead and stuff like that. So I'm like, oh, okay, yeah. And then, like I said, they data mine, and you don't want. So I was speaking to the young lady up here. They keep track of outliers. Okay, and when we talk in the next 2 hours, the last 2 hours, about your E&M leveling, you know, it's like a bell curve. Well, some people's bell curve is way off the chart. Okay, we're going to talk about that. You're an outlier, and don't think that they're not keeping track of that. Okay, and they're going to come after you. I know one hospital that I was just involved with in town, one of the physician groups was such a huge outlier, Medicare came in. and the hospital and the physician group had to pay money back. And you don't want that kind of scrutiny. You want to be like, you want to fly under the radar, right? Okay. The CERT is a group. I mean, it's a program where they take a bunch of charts and they see how they were coded and billed appropriately, and they have an error rate, okay? And you want that error rate as low as possible. Well, here you go. The fiscal year 2014, the improper billing they said was 12.7%, with estimated representing $45.8 billion in improper payments. Well, they're going to come after that somehow. So they're, compared to 2013, it was 10.1. So you see it's jumped. So don't think that they don't know that it's jumping. So either the coding is going out wrong, the doctors are coding wrong. In their opinion, it is wrong. The levels are wrong, the coding, and there's errors, okay? And they publish a work plan of things that they look for every year, okay? And here's some of the things they find. No documentation, missing notes or orders. So basically they're saying, I want to see the note for this surgery, and the hospital can't produce the note. Well, how in the world did you bill for that surgery if there was no note done? If the doctor didn't dictate the note, and if it wasn't dictated and it isn't in their system, it shouldn't have been coded and gone out the door, but it was. And so there's no documentation. That's you got to pay that back. All right, insufficient documentation, missing orders. Doctor needs to order for tests, that has to be all written down. Local coverage determinations not met. LCDs. Basically, an LCD is this. If you go on any website of any insurance company, okay, and they'll have, well, you know, and this is more Medicare, they'll have LCDs for certain procedures. So basically, if you're going to code colonoscopy with a biopsy, 453880, okay, there are certain codes you need to have on the bill to get that paid. That's all it is. You need to have one of those codes on that bill, okay? So you need to know all the local coverage determinations for a lot of the, some of them don't have local LCDs, but some of them do, like pain procedures. This is a good one. A spinal stimulator in the back, okay? You have to have a 338, it's either a 33821, 3384, it has to be a chronic pain code on the top, like chronic pain syndrome, chronic postoperative pain, chronic pain due to trauma. You have to have that as prime. And then you have to have underneath, like herniated disc of lumbar, 72210. You have to have two codes, but one of them has to be first, the other one has to be second to be able to get that paid. Do you see that? That's an LCD. So if you're not going to get paid, if you submit the diagnoses wrong or something that's not on the LCD, you're not getting it paid. Okay? All right. Missing signature, wrong date of service, not legible, coding errors, most for E&M codes. This is what we're going to talk about the last 2 hours. Okay, so E&M codes did not substantiate the code assigned. We're going to talk all about this later on. Okay? All right. Incident 2 guidelines. Is anybody familiar with Incident 2 guidelines? Okay, so basically, first of all, this is Medicare only. Okay? Because I don't think secondary insurance, like Blue Cross, they don't even recognize you all. Everything goes out under the doctor's name anyway. Okay? You're not even a valid, you know, but Medicare, you can bill Medicare under your MPI. Okay? But, okay, let's say this. And it's only in the doctor's office, not in the hospital. You work in a clinic for Dr. Jones. He's an orthopod. Okay? Dr. Jones is in the next suite and you're working in the room next to him. He's incident 2. That means he is in your suite, available to you. He's not off in the golf course by phone. He's actually physically there with you. Now he's not seeing the patient, you're seeing the patient. Okay? You can bill under his NPI number. And you can get billed for 100% of the service. Whereas if they bill under your NPI number, you get 80%. All right? But you have to jump through all these hoops to be able to bill under the doctor's name. And here's some of the rules. The PA must be employed by the doctor. This is only for Medicare claims, number 1. Must be employed by the doctor. The physician must initiate care. That means that the physician saw the patient the first time. Let's say you work for a derm guy. This happens all the time. Work for a derm, and the person comes in and they have warts or whatever, okay? They got some lesion, okay? The doctor sees them the first time and initiates the care. Okay, Mrs. Smith, you're going to come back, you know, for 5 different visits, and we're going to do this and this and this. See how the doctor has initiated the care. First visit, that's done. Check off, okay? And then He's used in the office setting. The doctor must be present and available, not off at the golf course, not on vacation. Okay? Doctor must be involved in subsequent visits. So let's say Mrs. Jones comes in for 10 visits. Maybe the doctor sees her at visit 6. Okay? And you see him for all the other visits. You can bill under his NPI number and get paid 100%. Now remember, when we're talking about all the lost money that falls through the cracks for a physician, that 20% is big. Over and over and over. Now, I just spoke with another gentleman here, and he's like, yes, with the Affordable Care Act, physicians are being overwhelmed because people are going, you know, and basically, you guys are going to write your ticket. I mean, period. You're going to write your ticket because the physician, a lot of doctors are becoming doctors because of the money. I mean, it's, I mean, I know you all have debt too, believe me, but you don't have physician debt and the years involved. So what you all are like gold, NPs and PAs, because you're physician extenders. It'll be one physician and multiple PAs. And you can extend him, see more patients with his care, seeing them occasionally or whatever, or billing under your own NPI, but working for him. Okay, like my daughter works for a doctor. She's working in 3 different hospitals here and the clinic. He has 1 doctor, 2 PAs, and he needs to hire more because they're overworked. So you know, you guys are going to be like, you guys are going to like, you're going to have jobs. They're going to be begging you before graduation. All right, believe me. Rachel had plenty of jobs offers before she even graduated. All right. If in subsequent visits a new problem arises outside of the original plan, so let's say they came in for lesions, okay, and then all of a sudden Mrs. Jones develops psoriasis. That's a different problem. Doctor's got to come back in and deal with that issue, set that plan of care, and then every other subsequent visit you can see them and bill under your his MPI and get the 20% more, okay? Or do you understand Incident 2 rules? Yes?
Now, I feel like this has maybe been brought up in different practices before as something that is frequently kind of like, maybe rules are more prone to be bending or people don't fully understand them. I mean, how would you address it? Is that something the coder addresses or something you as a PA are like, oh, I don't think this should be billed Incident 2, or?
Yeah, well, and who's it going out to under the doctor's MPI? Who's taking all the risk? The doctor is. You better doggone know the rule. You know, I worked for a compliance department, one of the contracts I was just involved in, and I basically, they had some questions about this derm practice and whether they were billing out Incident 2. And I had to figure out, okay, was the doctor even present in the suite during that visit? Because it billed out under his MPI, and he was on vacation. He wasn't even there. I'm like, bingo, that's a problem. Now, it's one thing if the compliance department finds that. It's another thing if the government comes in and finds that. They're going to want that money back. They're gonna hit you because at that point the burden's going to be on you. Like, well, this was only an isolated incident. Oh yeah, the government's going to say it ain't an isolated incident. It's a big problem. We're going to look at all of y'all now. You see, like I said, you do not want to stand out at all in this business. Okay? If the Incident 2, it's 100%. If it's not met, it's 85%. Sorry, my fault. 85. Point of emphasis of the government is they are looking at this, the Incident 2. And since PAs are going to increase in the numbers and volumes of you all, it's an easy find for the government. It's an easy. They're going to be looking because they're going to be like, oh yeah, you know. All right. EMRs, and you know that's going big now. Okay, the electronic records, and there's some cautions with them, and here they are. They use pick lists, drop-down boxes, filling in data fields. Some EMRs auto-populate information from prior visits. Okay, so basically it gets auto-populated into this visit, and you didn't do this on this visit. Okay, and then a coder comes behind and they're counting, and this is going to make sense in the next 2 hours. But they're counting how many ROS you had, how many HPI you had, all of that. And if you didn't even do that at that visit, then the coder is inflating the values and going to get you a higher level, and you didn't do it. And if the government comes in, or an auditor would come in, and they would say, okay, I want to see the notes for Mrs. Jones for all of her visits. That's what I would do. I want to see them all. And if they all look the same, we got a problem. Because remember, cloning is an issue. Because then the government's going to say, you didn't do all that information each time the same way, same verbiage. They're going to know you cloned it. They're going to know you copied and pasted forward. That's a big problem, and they're looking at that, okay? Templates used in AMRs can lead to cloned or cookie cutter documentation. EMRs count detail but not appropriateness. Listen to me. If you get nothing else of what I say, this right here is very important. We're going to talk about that the last 2 hours. Just counting, all the bean counting that we do to get to the evaluation and management levels. And like I said, if all that documentation is there and all that detail is there, the EMR sometimes picks its own code, and it could be wrong. That's why sometimes a set of eyeballs is good on that, okay? Especially if it's copy and pasting forward. It's not legitimate documentation for this visit. It was from last visit. You need to count what's this visit's stuff, all right? We're going to talk about that the last 2 hours, okay? E&M compliance is at risk. Coding engines that fail to consider medical necessity, okay, which CMS describes as the overarching criterion for payment. That right there is in a nutshell, okay? You shouldn't be doing anything that isn't medically necessary. And the level that you assign, and that's the last 2 hours, we're going to talk about that, the level that you assigned, it needs to be medically necessary, okay? So, I'll give you an example, all right? A 29-year-old, relatively healthy guy, no chronic conditions. He's 29. He woke up dizzy this morning, okay? He comes into the ER, dizzy, okay? Then you have a 75-year-old woman who has diabetes, hypertension, history of a stroke, and she was dizzy this morning. Oh, right there, that's a difference, right? Okay, should this one be paid probably a little higher than this one? Well, we'll see. This guy could be having a stroke. Who knows what the heck's going on with him? But let's come to find out, Mr. 29-year-old, he ran yesterday in a 5K, and he got a little dehydrated, right? So he's dizzy this morning. Okay, whereas this woman over here has a whole lot more risk because she has all these chronic conditions that you're managing that could be playing in all of this. Okay, and you're going to run a whole lot more tests, or maybe different tests, or keep her longer. Come to find out, you might even have to admit her. Big difference. Okay, that's medical necessity. Okay, okay, it's the overarching criteria for payment. The overarching criteria. We're going to talk about that in the next 2 hours. EMR may have design that consistently creates records with high levels of documented care for every visit and submission of high E&M levels. I've had scribes come to me, when I've taught, they were scribes in their prior life, and they said, we were told in the ER, make everything a level 5. Well, that's a problem. Everything a level 5, talk about being an outlier, you shouldn't be an outlier. What did I say about the ER that I worked with? 60% of our cases were level 4s, 5s in critical care, okay? That's a stroke and heart hospital. That's not like Lee Memorial down here, you know. Well, you probably do have a lot of older people in this area, so you probably would have a higher acuity. But like just like a regular ER, not a stroke and a heart hospital ER, okay? So you shouldn't have everything level 5s. Sheesh. Okay, we didn't have everything level 5s, right? And that was in a more high acuity hospital. Okay, 2 coding and billing mindsets for you to remember. Physician coding, you bill for your work, your risk. We're going to talk about risk afterwards. Okay, here's the nugget on risk. Person comes into the ER, okay, and they have chest pain. Okay, right now, all of a sudden, that's a pretty serious thing. You've got to take that serious, okay? So you're going to run everything. Chest pain protocol times 2, you know, and the whole gamut. They're going to be there 5-6 hours, easy. Boom, okay? And then you have to say to yourself, and after all the tests are run, you have to say, they're safe enough to walk out that door. And you have to run all the tests to say that they're safe enough to walk out that door, so they don't code when they're outside on the sidewalk, okay? So, and that's a risk to you, is it not? You're taking the risk. You have to run all the tests, and you have to basically say, okay, they don't need to be admitted, it was GERD, you know? All right? Or, no, I don't like the way that EKG's looking, I want a cardiology consult. And then come find out they admit them. That's risk, okay? And sometimes it's more risky for you to send that patient out the door than to admit them, okay? So that's risk, and we're going to talk about your risk. You should be paid for your risk, all right? Okay, so here we go. Your work, your risk, so document what you did so that you can get credit and get paid appropriately. Because remember, if it isn't documented, it didn't happen, so you have to document. Document that you did a 2-layer suture repair and not just a single layer, because the intermediate repair gets paid more. And if you did a 2-layer repair, you should get paid the 2-layer repair. Okay? All right, facility coding. I touched a little bit on this. They bill for utilization of hospital resources, drugs given, so all that. So basically, when I look at a hospital chart, I'm looking at nursing documentation. I'm looking at all that kind of stuff, okay? Because all of that goes into what in the world's wrong, and they get reimbursed for all of that, okay? And it gets, like I said, that DRG, and they can flip that DRG, and then you can get paid for a higher DRG. Okay, so as far as coding, you'll never code in a facility. You might code in a doctor's office. You might be coding your own charts in a doctor's office. It depends on the doctor's office you work in. But in a facility, you'll never be coding. But, because they'll have coders doing that. But the coders are at the mercy of your documentation. That is your burden in a hospital, is your documentation. And like I said, they're going to have people scrutinizing your documentation to get every last drop out that they can. Okay? They'll know what needs to be documented, and they'll teach you. Okay? All right. CPT, that's the book that's going around. Sheesh. You can tell I got it at 12:30 last night, can't you? Man alive. I flew in last night really late. Okay, so it is divided into the 10,000 range is the integumentary codes, INDs, sutures, biopsies. And by the way, the E&M codes, the 9-9s, that's what we're going to do the next 2 hours, okay? The 20,000 range is musculoskeletal codes. That's where you'll see fracture care, splints, all right? 30,000 is respiratory and cardiovascular system. 40,000 is digestive. You've got colonoscopies, gastric bypasses, EGDs. 50,000 is urinary. 60 is nervous system. Spinal surgery is in there. Laminectomies. Pain injections are there. Cataracts. 70,000 is radiology, 80,000 is path and lab, and 90,000 is a really cool section because it's got a lot of stuff. Stress tests, psychiatric services, PTs, injections in a doctor's office, they're all there. The drugs are there. All right, modifiers, they're on the inside cover of the book is the modifiers, okay? Modifiers are used on CPT codes, and they do exactly what the name says. They modify the code. So here, let's give some examples. Oh, right here, in Appendix A, in the back of the CPT book, is a detailed description. I know on the front cover it gives you the modifiers, but in Appendix A, it gives you a detailed description of all of the modifiers, a detailed description, okay? So it's good for you to know that. Okay, so here, let's talk about some of the modifiers, okay? All right, ready? I put a splint on both arms. It's the same code. If you submit the code once and twice, the second one's going to get denied because they're going to say it's a duplicate. You have to modify the second code saying that it's different than the first code. Okay? So in this case, I would put the splint code with just once with a 50 bilateral. Means I did 2 of them. Okay? And if you don't do that, you're going to get one paid, the second one's going to get denied, and you just lost that money. That modifier, that little 50, got you paid for that second one. Okay? Right and left. Let's see. Cerumen impaction. You know, getting cerumen out of the ear. By the way, that is not simple lavage. A lot of doctors and ERs want to code it simple, like squirting saline in there, and they say, oh, that's earwax removal. No. The code says use of instrument or physician skill, okay? So like a cerumen spoon, okay? Because it's a little more than just like a nurse can do that, squirt saline. That's not cerumen removal. Okay, so you want to see that. So if they did bilaterally, of course, I do the code once with a 50. If they only did the right ear, I do the code once with the right, okay? Fingers and toes, okay? And by the way, we're just like Europe. This is digit 1, digit 2, digit 3, okay? The thumb is digit 1, okay? And the same thing with the toes, obviously the big toe. So if you're doing a bunion surgery, and if you want to code a hammer toe on digit 2, 3, and 4 of the right foot, you've got to put different modifiers on the second and on all of them to show the insurance company I did 3 hammer toes, and they were on 3 different toes, and therefore I should get paid for 3 toes. Because if you don't, you're only going to get paid for maybe 1, and you lost the money on the other 2. That's what modifiers do. Modifiers help paint the picture, help the code go through. Otherwise, you're not going to get paid for some of them, and it's money lost. and we're against money lost. That's abhorrent to us, okay? Especially when you did the work, you should get paid for it, okay? And it all comes down to the code you choose, and sometimes the modifiers. All right? Here's a good one. RD, where are they? Huh. Okay, they are. LD. Like if you do if you work for a cardiologist and you do stents onto a heart, not on Blue Cross, not on Aetna, but on Medicare. If you put a stent on the left anterior descending or the right coronary artery, you got to put a modifier on that to say what vessel it was. Medicare wants that. That's a modifier. All right. This is how you read a CPT book. I have what's known as a mother code. I like to say they're mother codes, and then you got baby codes. Do you see them? You see the indentation? Okay. Whenever you see a baby code, you have to go back to the mother code, and the baby code includes the mother code part of it, and then the rest of the baby code. Okay. So sometimes the baby code is here, and the mother code is on a whole other page or another column. So you have to make sure you go all the way back to find the mother code for that code. And this is how you do it. Ready? Let's say I had a 2.6 centimeter, okay, repair done of the arm, simple repair. It's a simple repair. So here it is, simple repair, okay? And so I say simple repair of superficial wounds of the scalp, neck, axilla, external genitalia, trunk, and or extremities, including hands and feet, semicolon. Do you see the semicolon? The semicolon, that's what's included in the baby code. So the baby code includes this and everything in the mother code before the semicolon. Okay? So then I go down to 2.6 centimeters. Right? So that's a simple repair. So you take the baby code and you go back to the mother code, and everything prior to the semicolon, that's what's included in the baby code. You have to look for the semicolon. All right? Now look, you need to read very carefully. Look at this. Ready? Including hands and feet. Simple repair. Including hands and feet. Then over here you get to the repair for intermediate, and it says excluding hands and feet. Have to read very carefully. Have to read very carefully. Okay? All right? Oh, another thing. Prior to the codes, there's always verbiage prior to the codes. You see the verbiage that's there? It gives you a lot of information about when to code it, what this means, blah, blah, blah. Okay? Like in this one, decontamination, like if, let's say somebody's riding a motorcycle and they slide across a gravel road, and they've got gravel all in their knee. Okay? And you're sitting there picking pieces of gravel out. Okay? The CPT book says that's an intermediate repair, even if it was only a one-layered repair, because it was extensive debridement and picking out a particulate matter. The verbiage on the left-hand side talks about that. So therefore, that could be a potentially mischarge if a doctor doesn't know that. Okay? He should be getting paid for what? For what he or she did. You took the time to pick out 50 million little pieces of pebbles out of his knee. You just couldn't slap the stitches on there with the crap in his knee. You had to pick it out. Okay? Now I'm not talking just simple lavage of saline. You actually had to pick it all out. That's time. You should get paid for that. All right? All right. Here's a shoulder procedure, arthroscopic, and what we're gonna talk about here is this little baby right here. It is an add-on code. See down at the bottom, it'll even tell you what it is. It's an add-on code. And then right after the code, it'll say use this code, 29826, which is the subacromial decompression arthroscopically. It says use this in conjunction with these codes. So if I do an arthroscopic rotator cuff repair and subacromial decompression, there's the rotator cuff repair, and there's the subacromial decompression, and it says I can use the 29826, the SAD, with this code. You see it says I can use it with that one, then I get that paid. Okay? So that's what that little plus says. It's an add-on code. It cannot stand alone. You cannot code that alone. If you just did only a subacromial decompression and not the rotator cuff repair or the Mumford or the biceps tenodesis or a Bankert repair or anything like that, which is all the codes that this is used with, if that's all you did was a subacromial decompression, you have to go to the debridement code, and it tells you that. Okay? All right. All right. So basically, this is what this is. And then also underneath each code, sometimes there's more verbiage. Look for that verbiage, okay? All right. Okay, here's the EGDs, right? And so you've got, here's the mother code. There's the mother code, 43235. That's a diagnostic EGD. They did nothing. And then over here is all, like I told you, over here's all the baby codes. We have to go all the way back to over here to get the mom code. And basically the mom code is right to there. Right before the word diagnostic, because there's the semicolon. Okay? So basically it's an EGD with a biopsy, with, you know, a dilation of an esophageal stricture. Okay? All right. There we go. That's how you read them. All right, we're doing good. We're doing good. Okay, here we go. Here's some of the CPT codes that you will use in a regular doctor's office. I tried to like gather some for you guys, okay? Sutures, give me the size in centimeters. We're just like Europe. We gotta talk in metric here, okay? So give me the size in centimeters. Layered versus simple repair. We've already talked about layered versus simple repair. Don't miss the layered repair. Don't miss it, okay? Repair a foreign body in a wound, all right? Incision and drainage, simple versus complex. Okay, so you got an IND. Okay, so basically an IND is, you know what all that is. Okay, so what's the difference between a simple and a complex? Well, what I do is if they put a drain in it, if they pack it, that's a complex. And it's more money. Okay, don't miss that. All right, or multiple, if they do multiple INDs, obviously that's a complex one. Okay, splints, long arm and leg versus short arm and leg. Anything that goes over the elbow is a long arm. Anything that goes over the knee is a long leg. Most distal radius fractures is going to be a short arm cast. I mean a short arm splint. And then same thing with the leg. You know, sprain your ankle. It's usually. But anything that goes over the knee. Okay. Cerumen removal. We already talked about that. You must use a tool like a cerumen spoon. Joint injections. Small. Like the knuckles are small, fingers are small. Medium are like the wrist and elbow. And then large joints are the shoulder, hip, knee. All right? And remember, if they do it bilaterally, put that 50 on it and you get paid for both. Otherwise, you don't. Okay? There we go. OBGYN, hysteroscopy, tubal ligation, labor and delivery. There's rules on all of that as far as how many visits and the OBGYN one was, I think it's the hysterectomy codes, is whether it's 250 grams or more. And I always have to go to the path report. The heavier it is, you get paid a different code for that, okay? So, like I said, if you work in an orthopedic practice or an OBGYN practice or cardio, you get to learn all the nuances of all those kind of codes. But if you work in a practice that sees a lot of things, that's where you really get a whole lot of good practice across the board in a lot of things, all right? Shoulders and knees, we've already talked about the rotator cuff and the meniscus, okay, the knees and the meniscectomies in the knees. There are two codes for that. One of them was medial and lateral meniscus, and the other one is medial or lateral meniscus. Make sure you pay close attention to that code. Like I said, you have to read the codes very, very carefully, all right? That's how they try to trip you up. Colonoscopies and EGDs with biopsy, dilation, snare, or cold forceps. Here, let me give you an example of that. Okay, a colonoscopy. Okay, so they do a colonoscopy and they do a snare retrieval of a polyp, and then they do a cold forceps biopsy retrieval, biopsy. That's two different codes. That's paid both, right? And you need a 59 on the cold biopsy one. You code the snare one first, and then the cold biopsy one second, and you put a 59 on it. And a 59 means it's separate. Good. Let's go back to the modifiers real quick now that we're there, okay? Let's say I had a lesion here that I wanted to excise, and it's a benign lesion. They're both benign, because we're going to have the same code. A lesion here and a lesion here. They're the same code because they're the same size, they're the same morphology, they're both benign, okay? How in the world can I tell the insurance company that I did two? I can't do right and left. I can't do bilateral. They're on the same arm, but they're two different codes. I mean, they're two different lesions. I actually did the work for two different things, okay? And what you do is you put a 59 on the second one. 59 means, and that's your miracle modifier, 59. It means separate, separate lesion, separate site, separate encounter, separate, separate, separate. Yes?
What if they had 3?
I'd put a 59 on 2 and 3.
Okay, so
If they're the same code.
okay.
Because if they're not the same code, you know, because what is the insurance company going to do? They're going to deny the second and third one as duplicates. Because it's the same code with no modifier. They're going to shoot it out the door, and you're not going to get paid on it. So you put a 59 on it. Now, here is my caution on 59. 59 is a miracle modifier. It gets everything paid. It's like the lotto, okay? It's like you win every time. Yeehaw, you win, okay? But they keep track of how many times you use 59. And if you're using 59 all the time to get things paid, wrongly, legitimately is fine. Wrongly, they're gonna come in and they're gonna ask for documentation. And as long as you're doing the documentation and you're coding appropriately, you say, here, look at it. I'm fine. I sleep well at night. But if you're using the modifier wrongly, then you got something to worry about because they're keeping track. It's part of the OIG. They keep track of 59s. They do. Okay? So legitimate 59 usage is done. I use 59s, but I don't use it for everything. It has to separate. It really has to be separate. And herein is the example. The colonoscopy. They did a snare biopsy. And I know that's a separate code than the cold forceps biopsy. I know that, and it sort of went against what I just told you. But yet, the cold forceps biopsy, I know, is going to be rejected. It's going to be, unless you put 59 on it, because it's a separate lesion. But it was retrieved separate, different. One was a snare, and one was a cold forceps biopsy. Okay, but see, therein is the knowledge of a coder knowing that versus, you know, and like I said, if you work in this field in certain specialties, you'll learn all the nuances of it. Okay? Hernia repairs. Please tell me if it's incarcerated. Okay, because that's a different repair, and it's also a different I-9 code if it's incarcerated. Okay, bilateral, with mesh, reoccurrent, open versus lap. All of those are all different codes. Okay, lap cholecystectomies with or without intraoperative cholangiograms. That's 2 different codes. Biopsies and excisions. Again, we have to talk about centimeters there. Malignant versus benign. So that's why I never code a derm or any kind of excision without the path report. Because you got to have the path report to determine whether it's malignant or not. Because if it's malignant, it's going to change the CPT code. Plus, it's going to change the diagnosis code, but it's going to change the CPT code. Okay. All right. Layered closure, flaps, and grafts. That's all in. Derm is difficult to code. I have a real problem with it. But you know that's really tedious stuff. That and urology. Ooh, that's real fun. Okay, immunizations, intramuscular, oral, and that's another thing you can code in your doctor's office. All the drugs that they, they're doing a tetanus shot, you're going to code the administration plus the drug, if you bought the drug, because you're in a doctor's office, you probably did. Fingers and toes, modifiers and joints, important. Oh, and another thing, if you're doing a toe, like if you're a podiatry, and they do the interphalangeal and the proximal phalangeal. You got to really be real specific on your documentation on that as far as the codes. Fracture care with manipulation or without manipulation. Okay? So if you actually, reset the bone versus you just put a splint on it. Okay? If you did it, or did no manipulation at all. All right. All right. Here's an example of a procedure note. And here is the, this is an ER note. This is what an ER template will look like at most hospitals if they're still in the template mode. Okay, and here's the procedure. It's 4.5 centimeters. It's in the left eyebrow. So I just got my code right there. Okay, it says laceration of left eyebrow. There is no foreign body identified. The wound was explored. Okay, and they did a repair. Number 6 stitches of 6.0 nylon or whatever. So right there I know they've got a laceration of the eyebrow. It is not contaminated, so I'm not going to code a contaminated laceration. It's a simple, clean laceration. So there we go. Eyebrow laceration, boom. I'm going to code the repair, and it's a simple repair. It's not a layered repair. It's a simple, and it's going to go 4.5 centimeters. Right? Okay. Okay, hold on. Yep, okay, good. I gotta go through this too. I have 3 more slides. I gotta get you to number 47. All right. Outpatient coding rules. Okay, so outpatient is the doctor's office, outpatient is an outpatient clinic, outpatient is everything that isn't staying overnight, like multiple nights in the hospital, not observation status. That's still an outpatient status. But outpatient coding rules, you only code the confirmed diagnoses. Okay, so if they come in with chest pain and they come to find out that it's an MI, I'm coding the MI. Okay, I don't need to code chest pain because obviously that's like redundant, but they obviously had chest pain. Okay, let's say the doctor they came in for chest pain and they say rule out MI. I can't code the rule out. They have to definitively rule it out for me to code one way or another. Okay, I can only code confirmed diagnosis. If I don't have a confirmed diagnosis, what did I say at the beginning? You code signs and symptoms. Okay? You can code, oh, there it is. Hello, there it is. I gave you the answer. Do not code rule out suspected, likely versus uncertain, probable, or possible. In the outpatient world, you do not do that. Okay? So, and I've seen that. I have seen doctors do this. I have seen them, they are ruling out cancer of something, and they're coding it as cancer. That's a rule out. Come to find out they did the biopsy, and it's not cancer. You're putting cancer on someone's chart. You're putting cancer into their medical record. You're putting cancer onto them. There are certain codes that I really, really get scared about coding. And I want, like, you know, I'm not a doctor, although I had like a full year of A&P, so I have some knowledge of what you do, but I don't understand anything of what you do. But I don't code AIDS on somebody unless I have it legit. AIDS. Give it to me. If you say HIV, yeah, right. If you say HIV, I'm coding VO8, asymptomatic. I'm not giving you full-blown AIDS, which is 042. That's a big, that's someone's life. You understand? That cancer, I won't code cancer unless I know it's legit cancer. Because, I mean, people got to get insurance. Seizures is another one. I'm not going to give them epilepsy. I'll just code convulsions, like they had a, you know, febrile seizure or something like that. But I'm not giving somebody epilepsy. You know, there are certain things that I'm just a whole lot more scared about coding. And doctors, I'm just like, oh my goodness, they coded this person as having cancer and come to find out it wasn't cancer. They were ruling it out. Don't code it. Code, you know, unspecified neoplasm or unspecified lesion or whatever. Or they come to find out the path came back, it was a benign lesion. Code that. Do not code the cancer unless it's confirmed. Code any history codes or diagnoses that are still being treated or that affect care. That's a given. You have to take everybody's health into consideration, their entire past medical history in your decision making. If you have to consider that in your decision making, in the tests you run, in the drugs you push, then it should be coded. Okay? Because remember, you're getting paid for your risk. Okay? And that 29-year-old guy who's dizzy because he ran the 5K yesterday is not as risky as this 75-year-old lady potentially walking in the door. Potentially. All right, common I-9 coding issues. Okay, we talked about some of these. Cancer, please help me with the primary versus metastatic. Okay, help be very clear about that. You know, if you say metastatic liver cancer, primary unknown, boom, oh, that helps me out a whole lot. Okay, I know that the liver cancer is secondary and you don't know where the primary came from, and I'm going to do an unknown primary. Okay, pressure ulcers, and this is important if we go to I-10. Okay, you need to document where it is and what stage it is, if you know. If not, it's an unspecified stage. Because in I-10, right now, if I say pressure area of the sacrum, stage 2, that's 2 codes. In the I-10 world, they're all going to be balled up. It's going to be pressure area sacrum stage 1, pressure area sacrum stage 2, pressure area sacrum stage 3. That's going to be all involved in one code. Okay, so you have to, and they're real big on the stages. In the hospitals, they love to know that. They love to know the stages. All right, fractures, open versus closed. Be specific as to what part of the bone is fractured. Otherwise, I got to go to the radiology report. Is it the distal radius fracture? Is the ulna involved in it? Is, all of that. All right, acute versus chronic. We talked about that. Document the BMI. Okay, higher BMIs affect the DRGs in the hospital stay, and it's going to put it into a different DRG, and it's going to make the hospital more money. So document the BMI. Although I can go to a nurse's documentation or a nutritionist documentation for the BMI, but I cannot go anywhere else but you all for the obesity diagnosis. You have to set the obesity, and once you use the words obesity, morbid obesity, whatever. Once you set that, then I can go to the nurse's documentation and get the BMI. But if I see the BMI is like 42, and nowhere did you mention that either I'm going to put the thing on hold and query you. Well, I see the BMI documented 15 times by the nurse is such and such. What do you think? Because I need you to say it, and I can't lead you to say it. That's what got that one hospital in trouble, that the OIG came in. They were actually leading the doctors to saying certain things. Can't do that. I can ask you open-ended questions, okay? Like, well, I see a lab value here as such and such. Is this clinically significant? That's an open-ended question, and you can say no, and that's great. But I can ask that. I can't say, do you think they had anemia? I can't say that. Okay, I can't enter any kind of verbiage into the question, the discussion. I can't throw out anemia, but I can say, well, the hematocrit was a little high here, and it was documented here, and it wasn't clinically significant. And then you come back and say yes or no. All right, and then you give me my diagnosis if I need it. All right, hypertension with chronic kidney disease. This is one time where we can assume. As a coder, we can't assume much. Okay, we can't, like, you're the clinicians, we are not. We can't assume. But in hypertension and chronic kidney disease, we can. And so basically, this is the regular unspecified hypertension code, right here. If we have chronic kidney disease and hypertension, I don't even need for you to say it's linked. I already know it's linked. This is the one time I can link it as a coder. So this changes to this, and I put the chronic kidney disease with it. And the X is for the stage. Like stage 1 is 585.1, stage 2 is 585.2, end stage is 585.6, okay? And so this becomes this and this, if I've got that. So, and I see that all the time. This guy sitting right here earlier, he says, well, can't Epic pick up the codes? Well, you know what they ended up doing? They end up picking this code, and they pick this code. Because they say, the person has hypertension and chronic kidney disease. They don't pick up this and this. And so right now, that's a coding issue. That's a coding error. See, 'cause that you can't have this with this. You have to change this to this with this. And that's a coding issue. So see, the software doesn't really recognize that. So, that's where I'm saying sometimes the software is choosing the wrong stuff. All right? Diabetes, document any manifestations, because there's all sorts of diabetes codes, renal manifestations, neurological, ophthalmological, okay, and it changes the diabetes code, okay? And poorly controlled does not mean uncontrolled. Okay, now here, I'll give you an example. One facility I'm working at right now, I'm coding for an ophthalmology guy. Okay, and he's coding for diabetic retinopathy, and it's like a 362 code, and he's got the diabetes code as 250.00. That's unspecified diabetes. If he has diabetic retinopathy, because that's what the code says, diabetic retinopathy, then the diabetes code is now 250.50. That 5 means it's an ophthalmological manifestation. So it's 250.50 with the 362, which is diabetic retinopathy. And do you know why? That bill's not even going out the door. The edits are hitting, and it's coming back, and we're having to fix it. And see, that's the edit that this hospital system has put in place. It's not even going to go anywhere, because it makes no sense. So the coder has to get involved. So the doctor has to understand that's a 250.5. Anything that's ophthalmological, that's a 50. All right? All right, 2 more. V codes, screening. There we go. Screening for colonoscopies, there's your screening code. History of breast cancer, aftercare, removal of sutures. These are V codes. You'll code them. Encounter for chemo, your prime code should be that, and then the cancer after, like 174.9 if it's breast cancer or whatever. Contact or exposure with potentially hazardous body fluids. I code that in the ER quite a bit. People come in, they've, and vaccinations. Prophylactic influenza, so if they're getting an influenza vaccination or a tetanus, you gotta have a V code, or else the vaccination's not gonna get paid, okay? Kidney transplant status, V43.3, heart valve replacement status, I code that. Somebody comes in and they're on, Cumin or some sort of, blood thinner, because they've got a heart valve, okay? Something Lovenox or whatever the heck they put them on. I gotta code that, okay? So I code a status of a kidney transplant or a heart valve transplant or something like that. Heart valve replacement status. Routine exams for a child, that's another kind of V code. V codes are fun. Okay, here's your E codes. This is the last slide for your next. Okay, they tell how something happened. So here right now, it's falling off a bike, MVA. See that last digit, E812.0. That tells me it's the driver. If it was the passenger, it'd be 0.1. Okay, falling off a ladder, bit by a dog, struck by a ball. You know, and they also tell where something happened, and that's important for a workman's comp case. If somebody comes in and they've been hurt workman's comp, I better be putting some E codes on there that tell that it was done at work, and it's usually this one: civilian activity done for income. Okay, I put that on there because that tells the insurance company Blue Cross shouldn't be picking that up. This is a workman's comp case. This happened on the job. All right. Okay. Any questions so far? Okay, hold on. While I have you all here, I'm going to put these out here. You're going to need, when you come back, you're going to need one of these packs, one. And you're going to take one of the yellow things, and they are yours to keep. They fit into your pocket. I made them specifically for that reason. They fit nicely in your little white coat pockets, and they're your gift. Okay, so you're going to take that. And also, my business card is here, so you can take that and, dial me at 3 o'clock in the morning. I don't know. Okay, so you got 10 minutes. You got 10 minutes, and then the next 2 hours are going to be